I'm Al Ali, and I'm very excited that you're going to have surgery done with us. And I really would encourage you to spend some time looking at these videos because they're extremely helpful to your recovery. It's an exciting time for you, and we're excited, and we're here to help you. And I think these videos will help get you there. Okay, so we're going to talk about your upcoming belt lipectomy surgery. I would like you to know that it is very normal to be nervous before surgery. It's human as you go into something that's big, a major event in your life, to be nervous, and that's okay. If you have any questions that we can relieve your stress, please let us know. We'd be happy to answer them. I will tell you that the prescriptions that we would like you to get are going to be written on the day that you come in for your preoperative visit. We send them to the pharmacy that you choose, and we really much prefer that you pick those up before you come to the hospital, even though you're going to be in the hospital overnight. It's just better if you have them, you leave them at home. You don't need them in the hospital, but we want you to just pick them up. It's a lot better. And we're going to talk about them in detail a little bit later in this video. I mark you the day before surgery. Basically, I put marks on you in the areas that I'm going to be working on. It's basically the map of what we're going to do. It takes me a good 45 minutes to do, and it's very precise. And as you'll see as I do it, I'm looking for a lot of different things, but it is very important to what we do. It's probably the most important thing that we do for this kind of surgery especially. After that, your markings will be photographed, and I use those photographs to plan the surgery, and I also use them intraoperatively, or meaning at the time of surgery. So they're quite essential to what we do. On a day of surgery, I will see you before other people see you. I usually there pretty early. The nurses will be there. I will make sure that your markings are still okay. I will give you an opportunity to ask me questions that you may have thought of or you didn't ask me originally. After that, the nurses will prepare you for surgery. Anesthesia will come in and they will introduce themselves. They will also have you sign a consent for their part of the procedure. One of my trainees will come in after that and have you sign a consent. It's a requirement by the hospital, and we must have you do that, so don't be alarmed. This doesn't mean we're doing anything different. It's just a requirement that we do that. After that, you will be taken to the operating room. It's not likely that you'll remember much after leaving that area and going to the operating room. And the first thing you'll remember is being in a recovery room with a garment on. Generally speaking, the garment is going to be a binder unless we've done some work on your thighs, and you will have foam underneath it. You may have a catheter in your bladder when you wake up and you're in the recovery room, and most of the time you're going to have that catheter either till that evening or it's taken out in the morning. Now the catheter is put in while you're asleep, so it doesn't hurt, and generally taking out the catheter does not hurt, so you don't have to worry about that. When you wake up, you'll be on a hospital bed that you are going to be taken from the OR to your hospital room, and it will be kind of in the position of a beach chair. So it'll be slightly bent at the waist. There'll be a sign on the bed that says patient is not to be moved in any way to completely awake and alert. And why is that important? Well, in a belt lipectomy, you have tension in the front and tension in the back. And the only people who can sense tension by the time the surgery is finished is you. You are the only person that can sense if you're moving in one way or the other that's too much tension. And that's why we put that sign up. While you're groggy, you can't protect yourself. So we don't want anybody moving you. Once you're awake, even though, as we'll talk about, you'll have this local anesthetic in, you'll still be able to sense tension and you'll be able to protect yourself. Now, we expect you to get up the same day of surgery in the evening. The nurses will help you. Usually they'll kind of get you to the side of the bed and get you up. Now, again, you're the team captain when it comes to that, because we cannot sense your tension. The nurses cannot sense your tension. So if you feel like it's a little too much at one spot or another, you just say, hold on, it feels like it's too much tension. Let's move in a slightly different way. So that's kind of up to you. That's your responsibility as you get out of bed. Now, why is it important for us to get you out of bed? The worst complication that can occur with this surgery is that you could develop a blood clot that starts in your legs and go up into your lungs, and that's life-threatening. The best thing we know of how to reduce that is getting up and walking, and at least one time the night of surgery. Now, we do a number of other things. We put these pumps on your legs that kind of contract and release, contract and release. We also give you a dose of a very mild blood thinner, in the evening of that surgery. But of all those things, the most important thing is getting up and walking. So that's very, very important. The day of surgery, the nurses usually will start you on ice chips and see how you're doing, and then bump up your diet slowly, usually to liquids. Usually by the time you leave the hospital, you're not eating a full meal, although I am surprised sometimes people will be having a full breakfast if they're just not nauseated, but the nurses manage that for you. The next morning, the nurses will get you up and they will take you to the shower. They'll take the garment off, they'll take the foam off, and get you in the shower and help you take that shower. I think if you're gonna have somebody at home, and I highly recommend somebody help you with that they are there for that shower so they can see how they do it, and then they put the foam back and they put the garment back on. I expect you to take one shower a day for a minimum of 30 days. It's very important to keep the area low in bacteria, and it also, most people feel a whole lot better if they've had a shower. And we expect you to do that the very first day of surgery. It's one of the requirements before you go home. You're welcome to use any soap that you like. I would just prefer that you don't use soap that's heavily scented. So if you have any soap that's hypoallergenic, that would be great. There are some soaps that are just there to reduce bacteria. You're welcome to use those. Just anything that you're not allergic to is okay. And you can put them on the incisions, just don't rub them. We inject a local anesthetic that is long-lasting in every area that we operate on. And it lasts for anywhere from 48 to 72 hours. To tell you that this medicine has changed the way we do surgery is an understatement, because before it, patients could be quite miserable. Since we started using it, it has been a godsend. It is wonderful. It really makes the experience considerably better. And it is the mainstay of our pain control after surgery. The worst pain occurs within the first 6 to 8 hours, and definitely you're covered during that period with that anesthetic. And as it slowly wears off, it doesn't wear off instantly. It wears off very slowly. You start taking these other medications, which we'll talk about. We put you on 4 other medications for pain control, as well as some narcotics, but we'll talk about that when we talk about medications. When you get home, it is essential that you get up and walk a minimum of 6 times a day. And we don't want you in bed. So you're either up in a chair or you're walking. Bed is only to take a nap or bedtime. Being in bed increases your risks of blood clots in your legs significantly. That's the one thing you have control over. Please get up and walk 6 times a day minimum. And if you could do more, we're more than happy to have you do that. We don't use any external sutures in anything that we do in a belt lipectomy as well. So all the sutures are internal, and we cover all the areas of the incisions with glue. Now, you can sometimes feel some sutures coming through the skin, and over the next few weeks, you might feel that. But these sutures are not external sutures. We usually just cut them at the skin if there's a problem. If they're really bothersome to you, you can come in and we'll cut them for you. Or if they're not bothersome, you can just leave them alone until you come in and see us, and we'll make a decision about that. We don't use drains on anything. The reason for drains is to reduce the risk of seromas or fluid collections. Fluid collections can occur anywhere that we've operated. So the best way that we've found to reduce the risk of those seromas or fluid collections from occurring is to use this internal suturing that we utilize. So we put a lot of internal suturing in a particular fashion to reduce essentially something called dead space on the inside. And we combine that with some medications that we gave you after surgery to reduce the potential fluid that can be dished into the wound. And we'll discuss that in the medication section extensively. We've not completely eliminated seromas or fluid collections, but I'll have to tell you, since we stopped using drains and used this regimen, our seroma rate is remarkably lower. And we feel that patients do much better without drains in the first place. And it's really been a very good experience for our patients. We inject every area that we operate on with a local anesthetic that lasts anywhere from 48 hours to 72 hours. It's an amazing medication, and it really works out really, really well. It has changed the way we do surgery. Patients really are much, much more comfortable than previously. The worst pain occurs within the first 6 to 8 hours after surgery, and certainly during that period of time, that medication is very effective. And as it slowly wears off, it doesn't wear off instantly. It wears off very slowly. You start taking these other medications, which we'll talk about. What are those 4 pain medications other than the injectable material that we use in the OR? First, we use high-dose Tylenol. Second, we use gabapentin, which is a direct nerve pain reliever. And then the one before last is we use Celebrex. Celebrex is very much like Motrin, but it's a longer lasting medication. And I know some bariatric surgeons don't like you to be on that drug or that class of drugs, but we've had some pretty good success as long as it's a short period of time while you're recovering from surgery. The last medication that is a non-narcotic is a steroid that we use. Now, this steroid is a pack of 6 days of steroids. You start out with 6 pills, then the next day it's 5, 4, 3, 2, so you decrease each day. The way steroids work is they reduce inflammation and they also reduce swelling, which is an indirect painkiller. So we would like you to take that. All 4 of these work on different mechanisms. So you could take them all together or you could take 1 or 2, but except for the steroids, I'd like you to take that all the time. The other 3 you can alternate or not use them or use them as needed. The last medication that we use for pain, and I really discourage you from using, is a narcotic called tramadol. We only give you 10 pills and we won't give you another refill on that. Narcotics have some pretty bad side effects, and in particular, in the kind of surgeries that we're talking about, it can cause significant constipation, so much so that you have to go to the emergency room. So we prefer that you don't use it. Only use it if you absolutely have to. Now, if you're gonna use it, we also give you something called Colace, which is a stool softener. Please use both of those together. If you use the tramadol, use the Colace, it'll help you. Now, if you do anything else that helps you move your bowels, please do that. Whether it's drinking coffee, certain foods that really get you going, but we really want you to have a bowel movement as early as possible. Other medication that we use is related to the fact that we don't use drains on anything that we do. It's a very mild diuretic and it's called hydrochlorothiazide. The short term is HCTZ. It's a very low dose of this medication and it gets rid of fluid from your body. A lot of the pharmacies will ask you if you have hypertension because it's usually used for high blood pressure. It's not being used for that in this particular situation. It's just to reduce fluid from your body. People tell you to drink a lot, very large amounts of fluid after surgery. We really don't want you to do that because what happens after surgery is all that fluid will go into the area that we operated on. It can cause fluid collections, which are called seromas. So we want you to drink, stay hydrated, but only enough so your mouth is not dry. And this medication will be the one that you'll be using the longest. It's for 30 days after surgery. The last medication that we will give you is something that helps you reduce nausea. It's called Zofran, and you only take it if you're having trouble with nausea. Again, all of these things are going to be at the pharmacy, and please pick them up as soon as you can prior to surgery. The patient information sheet, which you probably already have, we will give you again in the preoperative period, and it really has pretty much all the information that's included here in this video, but we just want you to have it in written form. You can refer to it, and it's a very good source of information for you. If there are questions that are not answered, please don't hesitate to contact our office.